All right, welcome to Clinical Crash Course. I'm Dr. Collins, and listen up. This is your mission briefing for one of the most important topics in all of medicine, coronary artery disease. Now, before we charge into the details, we need a plan, a map. This is Module 0, the roadmap.
So, why a map? Look, the enemy we're facing, it's a giant. This isn't just some textbook disease. We're talking about the #1 killer worldwide. The stakes could not be higher. And that's exactly why we need a crystal clear, strategic plan of attack.
Okay, but Dr. Collins, coronary artery disease it's just massive. I mean, it feels so overwhelming. Where in the world do you even begin?
That is the million-dollar question, Sarah, and that's exactly what we're here to answer. But first, you know the drill, our standard protocol. This content is for your board prep. USMLE, international boards, you name it. It is not medical advice. Okay, let's get to it.
All right, here's the game plan. This is how we're going to take down this beast. We've broken this whole monster of a topic into 6 logical steps. I want you to think of it as the life cycle of a heart attack, a story that unfolds from that very first blockage all the way to the final, most dangerous complications. This is our framework. First up, step 1, the supply. It's simple, right? You can't fix a plumbing problem if you don't know the pipes. We're talking core anatomy. We're going to touch on the infamous LAD artery, the Widowmaker, and the absolutely critical concept of coronary dominance. Now, for the full in-depth blueprint of all this, you're going to head to Module 1.
Okay, so we know the anatomy. What happens when it gets blocked? And that, Sarah, takes us right to step 2, the spectrum. This is the big fork in the road for coronary disease. We have to know the difference between stable angina, that predictable, almost chronic chest pain, and the absolute killer, acute coronary syndrome, which is all about a sudden, catastrophic plaque rupture. We're going to break down all that pathophysiology in Module 2. And this right here just lays it all out. On one side, you've got stable angina. Think of it as a supply and demand issue. A narrow pipe just can't keep up during exercise. But on the other side, ACS, that's a full-blown catastrophe. A sudden plaque rupture, a clot, they are 2 totally different animals, and treating them the same is a fatal mistake. So the plaque is ruptured, the patient is having chest pain. How do we find the clot? Exactly. And how do we find it? We pull out the map, and that's step 3. The ECG is our diagnostic GPS. It lets us pinpoint the location of the infarct, telling us if it's an inferior wall MI versus an anterior one. Mastering these ECG leads is non-negotiable, and that's exactly what we're going to do in Module 3.
And, on every good map, there's a big "Here be dragons" warning. For us, it's this. You have got to learn to avoid the deadly right ventricular infarction trap. Missing this, well, it can be game over.
We found the clot. What do we do now? Now we execute the rescue. Welcome to step 4. This is all about those first life-saving moves in the ER. We'll hit the Mona-Bash protocol, talk about aspirin, nitrates, and even the new rules on oxygen. To get the full deep dive on every single one of those acute drugs, you're going to Module 4.
So, the patient is stable for now. But what about the blockage itself? That is the million-dollar question, isn't it? Do we stent or do we cut? This is step 5, the fix. Here we compare PCI, that's stenting, with CABG, which is full-on bypass surgery. We're going to get into the critical guidelines, especially why diabetics with their diffuse disease almost always need the full surgery. All the complete surgical guidelines, they're waiting for you in Module 5.
So look, here's the choice in a nutshell. Are we going in with a minimalist approach, basically propping the vessel open from the inside with a stent, or do we have to build a whole new highway around the traffic jam with bypass surgery? 2 very different tools for 2 very different problems. Choosing wrong has huge consequences.
And finally, the patient goes home, only to come back crashing 3 days later. What on earth happened? And that nightmare scenario brings us to our final critical step, step 6, the aftermath. We're talking about the deadly mechanical complications that can pop up days, even weeks after the initial event, things like a papillary muscle rupture or a VSD. We're going to cover the dreaded timeline of death in Module 6 so you know exactly what to look for and when.
So there you have it. That's the roadmap. Now, I've got a question for all of you out there. Looking at this whole journey, what's the one part that makes you a little nervous? Is it trying to master all those squiggly lines on the ECG? Or is it memorizing the super specific indications for surgery? Drop a comment below. Seriously, let us know. We want to help you tackle your weak points head on. All right, Sarah, let's lock this in.
It's time for the memory anchor. The whole journey, let's nail it down. First, you map the territory. Then the plaque will break.
You locate the damage.
Then you stabilize the patient.
You fix the vessel.
And finally, you help them survive.
Let's do it one more time, all together. Feel the rhythm. Map, break, locate, stabilize, fix, and survive. That is your path. That is how you will conquer coronary artery disease.
Okay, I've got the plan. Fantastic. All right, everyone, your journey starts right now. Your first mission is waiting. Click on that playlist, subscribe to Clinical Crash Course, and I will see you in Module 1, The Widowmaker. Let's go.